Interesting. And thank you, Mark.
Well, thank you very much, Pat. And let me welcome my good friend, John Lang. He has been with us in the past. And it seems every time we have a program, John, there are so many new things to cover. It is truly fascinating. So delighted to have you here. Just a few words about Ambassador Lang. He had a distinguished 28-year career in the Foreign Service. He served as our ambassador to Botswana, special representative to the Southern African Development Community. And he is someone who is a specialist in what is called health diplomacy. And I have to say, on a personal note, I first met John at the Foreign Service Institute, I think when I was going out to Africa, first as a deputy chief of mission and then as ambassador to Equatorial Guinea. And I remember us talking about health diplomacy. When I was in Equatorial Guinea, first of all, I was involved in an initiative by the CDC, the Centers for Disease Control, on polio eradication. And that was something that John had worked on. He was involved in this initiative. He worked for the Bill and Melinda Gates Foundation back from 2009 to 2013. So I got involved in the importance of health in a foreign country. And then, of course, there was Ebola. And I was in a West African country. And once again, I had to learn an awful lot about the World Health Organization and all of the resources that we have out there. I guess in thinking about today's program, we all are so focused on Ukraine. And yet John's topic could not be more timely, because not putting aside the horrible things that are happening in that country, really responding to COVID-19. We are not free of that pandemic yet, but looking to the future, looking to the next pandemic, and looking to health security, on which John is an expert. So with that, I'm going to turn it over to you, John, and thank you very much. I also am going to get off the screen. Look forward to your talk. Bye-bye.
Thanks very much, Mark. And I remember well your hospitality when I visited you in Equatorial Guinea to talk about polio eradication with the government. Appreciated it very much. And thanks to Pat for the invitation and the ability to speak to you again as part of your global climate change series. Today, what I'd like to talk about are latest developments in global health security, and basically three components: the impact of the environment and climate change on global health, the status of the response to the current pandemic, COVID-19, and proposed reforms to improve preparedness and response for future pandemics. In terms of the impact of the environment and climate change on global health, it's really such a wide range of issues, from chemicals, radiation, and air pollution, to water and sanitation, to vector breeding sites, to climate change. There are just multiple causes of morbidity and mortality stemming from the environment. And changes in the climate influence the transmission of pathogens. Dengue, chikungunya, Zika, Japanese encephalitis, West Nile viruses, etc., by expanding the habitats of various common zoonotic disease-carrying vectors, like certain types of mosquitoes and ticks. That connection between the environment and health is very clear. In January of this year, the U.S. Environmental Protection Agency and the World Health Organization signed a 5-year memorandum of understanding to continue their collaboration on a wide range of specific and cross-cutting environment and health issues, particularly air pollution, water and sanitation, children's health, and health risks due to climate change. EPA's mission to protect human health in the environment aligns with WHO's charge to lead global efforts to promote health for everyone, everywhere. So they did establish this new MOU. WHO estimates, and I found these figures to be kind of astounding, that 24% of all global deaths, that's roughly 13.7 million people per year, and 28% of deaths among children under 5 are linked to the environment. And the people in low and middle income countries are the ones who have the greatest disease burden. 2 years ago, WHO released its global strategy on health, environment, and climate change. They believe that clean air, stable climate, adequate water, sanitation and hygiene, safe use of chemicals, protection from radiation, healthy and safe workplaces, sound agricultural practices, health supportive cities and built environments, and a preserved nature are all prerequisites for good health. So they do have this strategy on health, environment, and climate change. And also, shortly after the Director General of WHO, Dr. Tedros, took office in 2017, they announced a special initiative in collaboration with the UN Climate Change Secretariat to address the impact of climate change on health in small island developing states. And while clearly climate change affects all populations all around the world, some are more vulnerable than others. And in WHO's view, small island developing states are on the front line, encapsulating the full range of acute to long-term risks that includes more extreme floods, storms, and drought, increased risks of water, vector, and foodborne infectious diseases, increased risks of non-communicable diseases, and sea level rise threatening fragile healthcare facilities, mainly but not exclusively situated in the coastal cities. Their vision is that by 2030, all health systems in small island developing states will be resilient to climate variability and change. Earlier this month was World Health Day on April 7th, and on that day, Dr. Tedros, the Director General of WHO wrote, "The climate crisis probably remains the largest and most complex existential challenge of our time that needs unparalleled action. A heating world in general is bad for health, with 7 million people dying every year just in connection with air pollution." Now, a key concept that connects the environment and health is called One Health. And I believe I mentioned this in one of my previous presentations to the forum. CDC defines it as One Health is a collaborative, multi-sectoral, and transdisciplinary approach working at the local, regional, and national and global levels with the goal of achieving optimal health outcomes, recognizing the interconnection between people, animals, plants, and their shared environment. One Health includes issues such as zoonotic diseases, those that are transmissible from animals to humans, antimicrobial resistance, food safety and food security, vector-borne diseases, environmental contamination, and other health threats shared by people, animals, and the environment. The majority of emerging infectious disease in humans are zoonotic in nature. One of the prime examples, and I'm sure you're aware of this, is the AIDS, the acquired immune deficiency syndrome, first recognized in 1981. And it's likely that chimpanzees had AIDS long before the emergence of HIV in humans, with genetic changes occurring as simian immunodeficiency viruses crossed from monkeys to apes and from apes to humans. And HIV later mutated into human-only strains. But it's a clear example of that connection between animal health and human health and the environment. Another example, which you heard Ambassador Esquino talk about, is the Ebola virus. That was first discovered in 1976 near the Ebola River in what is now the Democratic Republic of the Congo. And since then, it has infected people from time to time, leading to sometimes terrible outbreaks, as happened in West Africa in 2014. Based on similar viruses, scientists believe that Ebola is animal-borne, with bats or non-human primates being the most likely source. And it's still around. Health authorities in the Democratic Republic of Congo declared a new Ebola outbreak last Friday, after the first case was confirmed in the city of Mbandaka. It's in the Northwest Equator province. And they've since then had a second case. This is the third outbreak in that province since 2018, and the 14th Ebola outbreak for the country since 1976. The regional director for Africa for the World Health Organization gave kind of the good and the bad about this. The time is not on our side, she said. The disease has had a 2-week head start, and we are now playing catch up. But the positive news is that health authorities in the Democratic Republic of Congo have more experience than anyone else in the world at controlling Ebola outbreaks quickly. So let's hope that one can be controlled quickly. So here you have all of these diseases, many of them emerging from the animal kingdom, that have come about in the last decades. HIV/AIDS, SARS from 2003, H5N1 in 2005, H1N1 2009, Middle East Respiratory Syndrome, MERS, Ebola, others. We've had these warning signals that we needed to be prepared for more pandemics in the future, because some of them got to be quite scary, as SARS did until it was put under control, and Ebola in West Africa. And what we certainly want to avoid is a potential catastrophe on the scale of the 1918-1919 Spanish flu that killed some 50 million people worldwide. But as you know, the focus and the funding in the United States and other countries has been based on a cycle of panic and neglect, rather than on sufficient regular appropriations every year passed by the US Congress and parliaments around the world. And we've all been suffering now with COVID-19. The origins of that are unclear. Actually, the US intelligence community released a report in August of last year in which some elements of the intelligence community believe that this was caused by natural exposure from an animal infected with COVID. There's extensive wildlife and livestock farming, wildlife trafficking, live animal markets in China, coupled with historically lax government regulation of these activities. But other elements of the intelligence community assessed with moderate confidence that the first human infection with this particular virus called SARS-CoV-2 most likely was the result of a laboratory-associated incident. We may never know the truth, since this would require China's cooperation, and the government continues to hinder the global investigation and resist sharing the information. But no matter what the source of COVID is, it has affected the entire planet. According to Johns Hopkins University, over 6.2 million people are reported to have died from COVID. And many people think that in certain parts of the world, especially in Africa, where they don't have the same health data systems, the number is much larger than that. There have been some positive developments. The Access to COVID-19 Tools Accelerator, it's called the ACT Accelerator, which was created by Gavi, the Vaccine Alliance, by the World Health Organization and other partners, has developed, and the purpose was to develop and equitably deliver vaccines, therapeutics, and diagnostics. They've enabled many countries to begin their COVID-19 vaccination campaigns. They've delivered over 1.4 billion vaccine doses to 145 countries, although that's lower than they had hoped initially. And they're the ones who helped build the sequencing capacity in Southern Africa that first detected the Omicron variant. And they've negotiated unprecedented deals with the world's largest oxygen suppliers to increase access in more than 120 countries. Globally, over 11.2 billion vaccine doses have been administered. But that's easy for those of us in the United States to say, because hopefully all of us on this conversation have been vaccinated and have had our boosters. Vaccine inequity continues. It's been a constant theme and a constant complaint of the WHO Director General and others. There's really a striking divide between the haves and the have-nots. And Africa has the slowest vaccination rate. less wealthy countries were relying on the vaccine sharing arrangement called COVAX. It's part of that Act Accelerator that I mentioned earlier, but they haven't been able to meet their goals of vaccine provision to the developing countries due to production problems, export bans, and vaccine hoarding by wealthy nations. Just yesterday in the print edition, the Washington Post published an editorial highlighting the fact that, quote, global vaccination is losing momentum. But if you look at the numbers, according to WHO, high-income countries and upper middle-income countries have achieved 74% uptake of primary doses. Lower middle-income countries, it's down to 51%. And in the lower income countries, the lowest income countries, at 665 million people, the uptake on vaccines is 11%. What a contrast to the 74% in the high income and upper middle income countries. The WHO's target for this had been to immunize 70% of the population by June, 2 months from now. But so far, that's only been met in 52 out of the 194 member states of WHO. Not a single lower income country, and only 3 of the 54 lower middle income countries have reached the goal of 70% of the population vaccinated. And many of the poorest countries are below 10%. But what's different now compared to the last time I talked to you, and really different from any time since the vaccines were first available, supply isn't the problem. That's no longer the main bottleneck. Many poorer nations, which originally were chafing at being left behind, now are not concerned about the supply. It's on the demand side. Some of that is what they call vaccine hesitancies, that people are reluctant to get the shot because they've been hearing disinformation and misinformation. But a lot of it is the logistical hurdles. And anybody who's ever lived in sub-Saharan Africa or other areas of the world that are still developing knows this, how difficult it is. I was just talking to a former ambassador from Sierra Leone who also works at the UN Foundation with me. And we were talking about how here you have some of these vaccines, the mRNA vaccines that require super cold refrigeration and freezing capabilities. And meanwhile, I've been at health units in southern Ethiopia and rural Tanzania and elsewhere, where you see a kerosene operated refrigerator, and usually it's not functioning very well. And there's just no way they could keep these vaccines in that ultra cold temperature that's required for the supply chain. So it's something that I knew, and many of us knew, when these vaccines first started becoming available, that it was just not going to be possible to reach many rural areas in a lot of these sub-Saharan African countries and others. There's another factor that's affecting this, which is other diseases, from measles to malaria, remain pressing threats and are competing with coronavirus vaccines for scarce resources. According to the Biden administration, efforts by USAID, the U.S. Agency for International Development, to help surge support for vaccination to the neediest countries will be curtailed in the future if Congress does not act by approving approximately $5 billion in global COVID funding. If you've been following this at all, that was originally part of the plan, but at the last minute was removed from the House bill, the House Appropriations bill, and was not passed by Congress about a month ago because of political reasons. And the Republicans wanting to see more verification of where vast sums that have been appropriated for COVID have been spent, and also questioning whether more was really needed. But the Biden administration is still pressing for this $5 billion for the global effort. Now, on a positive note, in Africa and elsewhere, there's been a decline in infections and deaths in recent months. It is ebbing in some ways. Tony Fauci was on a radio interview today and said that from a U.S. perspective, we've passed the acute phase of the pandemic, but that doesn't mean we've passed the pandemic. He was clarifying remarks he had made yesterday that seemed to indicate otherwise. And the goal that WHO had to immunize 70% of the world population by June is something that now people are rethinking because of these logistical problems I mentioned, because the deaths are going down because of Paxlovid and other therapies that have become available. And instead, some people are arguing that the goal instead should be 90% or more of target groups, such as health workers, older adults, pregnant women, and other high-risk groups. From the perspective of global health security, which is the perspective that I tend to take on this issue, we need to keep in mind that the virus never stops evolving. All the major variants that we know about through the letters of the Greek alphabet have originated outside the United States. The best way to avert a new one arising is to vaccinate as many people as possible around the world as soon as possible. So that's where things stand today in terms of COVID. Now, what does the future hold? WHO believes that COVID-19 can only be downgraded as a global threat once vaccines and new antivirals are rolled out equitably, with robust systems of testing and sequencing built up so new variants can be detected early and responses quickly adapt. There's been a flurry of activity in the global health world that I'm part of in terms of conferences, meetings, proposals, etc. When you talk about what the future holds, there's an immediate future, which is May 12th. On that day, the United States, Belize, Germany, Indonesia, and Senegal will hold the second global COVID-19 summit, following up on the one that President Biden initiated last fall. And so on May 12th, the idea is to have this meeting with the goal of reducing collective efforts and to prepare for future health threats. I hope that this succeeds, but I think that President Biden would have more influence on this if Congress had passed that $5 billion for additional global COVID funding. On planning for future pandemics, that's really what a lot of focus is on, besides the response to the existing pandemic. And you can argue that there's been an epidemic of proposals on how to change the world so we are better prepared and, if possible, can prevent future pandemics. Today, I'm going to focus on a few things here because there's just so much out there in terms of proposals. One is the negotiations for a pandemic treaty. Secondly, the proposal to establish a funding mechanism based at the World Bank. And then WHO's new concept that they're still developing called strengthening the global architecture for health emergency preparedness, response, and resilience. Now, let's talk about an international instrument or treaty. On December 1st of last year, on the last day of a special session of the World Health Assembly, the member states of WHO, 194 countries, agreed to establish an intergovernmental negotiating body. So in global health circles these days, everybody talks about the INB, the Intergovernmental Negotiating Body. Their role is to draft and negotiate the WHO convention, agreement, or other international instrument on pandemic prevention, preparedness, and response. So it may be a treaty or a convention, but it could be another international instrument. In fact, the US has been arguing to keep that broad or what the possibilities are. And the idea is to have this intergovernmental negotiating body, the INB, have a proposal to be considered at the 77th World Health Assembly, which will take place in May 2024. That's 2.5 years from when this was first agreed upon on December 1st of last year. Now, this instrument may be in the form of a treaty, which would require countries to opt in. You would require each country to ratify it. We all know the US Senate these days hardly ever ratifies international treaties. And maybe that's one of the reasons why the US government has been a reluctant supporter of that particular kind of instrument. Meanwhile, the Council of the European Union has been an early proponent of a treaty. The EU believes that an international convention or agreement on pandemics should support and focus on early detection and prevention of pandemics, resilience to future pandemics, response to any pandemics, in particular by ensuring universal and equitable access to medical solutions, such as vaccines, medicines, and diagnostics, a stronger international health framework with WHO as the central coordinating authority on global health matters. And the EU is also proposing that this be under a One Health approach. As I said, the one that connects the health of humans, animals, and the planet. Now, a cynic could say it's easy for the EU to talk about the need for equitable access to vaccines, medicines, and diagnostics, when in general, a lot of the countries in the global north, including European Union member states, have been trying to help themselves and their own populace first with vaccines before vaccines were given to the developing countries. But this is talking about the future, and there are a lot of good ideas there. The devil will be in the details. Delegates from the member states of WHO will be negotiating over two years before we get to May of 2024. And I'm not convinced that they'll solve it in that amount of time. The problem is there's so much out there, and there's just all kinds of ideas of what needs to be included in this pandemic treaty. David Fidler of the Council on Foreign Relations listed what advocates for a treaty have variously argued it should address. And this is among other things: disease surveillance, outbreak notification, the sharing of pathogen samples and genetic sequence information, zoonoses, the One Health concept, pandemic prevention, trade and travel measures, equitable access to health countermeasures, health capacities in low-income countries, and that goes along with universal health coverage, the social determinants of health, water, sanitation, etc., intellectual property rights that are owned by the pharmaceutical companies that produce the vaccine, misinformation and disinformation and all those problems in communication and social media, financing for pandemic preparedness and response, human rights issues, strengthening the World Health Organization, et cetera, et cetera. And I must say gender disparities are another issue that we brought up. All of those things are important. All those things need action. How they can all fit in a treaty, I just have no idea, because it is so difficult to get agreement from all 194 member states, or even a sizable group of them, if the treaty is approved by some but not all, on so many issues, including such a vast array of issues. So it's really going to be something to see how these treaty negotiations proceed. And my guess is that you're going to find a lot of disappointed people, the people who really wanted this to grapple with the issue of intellectual property rights or misinformation or zoonoses or whatever, are going to be disappointed because it didn't do all what they see as being necessary. But as one retired diplomat told me, it's not a matter of what we need, it's a matter of what we can agree on. And that will be the tricky part of these treaty negotiations. It's too early to tell now how they will go. I think it's worth noting that there has been action on the existing framework for global health security, which are the International Health Regulations, IHR. The World Health Assembly at its annual meeting this coming May, on May 22nd, will consider a US government proposal to amend the international health regulations that were first approved in 2005. The IHRs are fundamental to global health security, but they're not as expansive as a treaty would be. In those IHRs, 196 countries have agreed to build their capacities to detect, assess, and report public health events. WHO plays the coordinating role and together with partners helps countries to build their capacities. The IHRs also include specific measures at ports, airports, and ground crossings to limit the spread of health risks to neighboring countries and to prevent unwarranted travel and trade restrictions so that traffic and trade disruption is kept to a minimum. Many believe that the experience of COVID-19 has demonstrated that the IHRs need to be revised and improved. And the US government has a proposal, but I think there are a lot of indications that it won't just be approved, even though the ideas are quite good, because what I think the World Health Assembly next month is likely to use to provide for more time so that other countries can provide their own proposals to this. US government met a deadline, I believe it was 4 months in advance of the World Health Assembly, and other countries weren't able to meet that deadline. The difference between a treaty, which has to be approved by senates and congresses and parliaments around the world as a country opts into it, is that the IHRs are an opt-out mechanism. WHO member states agree on what the text should be, and then each member state has the possibility of opting out of the specific language within a certain time period. And if they don't opt out, then they're legally bound. That's how you can get changes in the international health regulations approved by the US government, because the Senate, the US Senate would have to opt out and take a positive action not to have this apply. And that tends to be not the case. But as I said, these are more limited than what a potential pandemic treaty would be. Another issue that's out there is the funding. None of this is going to make any difference if there isn't sufficient funding. No matter what you say you're going to do in terms of improvements for pandemics of the future. WHO and the World Bank estimate that there's a $10.5 billion annual gap in financing for pandemic preparedness and response. That's the minimum amount of additional financing required to support equitable global access to vaccines in the future, as well as testing and therapies, global disease surveillance, research and development for new therapeutics and vaccines, manufacturing of vaccines, and health system strengthening. And many people believe that one of the key lessons learned by the developing world through this pandemic has been that they can't trust the developed world to equitably share the vaccines, and they need to have vaccine manufacturing capability in the developing world so that they can prepare vaccines for themselves. Indonesia is the current president of the G20 group of nations, and the Indonesian finance minister announced just in recent days that most G20 members have agreed on the need for a new financial mechanism dedicated to addressing the financing gap in pandemic preparedness. They have urged the World Bank to immediately prepare for the establishment of what is called a financial intermediary fund. And that's a concept that's been strongly supported for months now by the United States. These are arrangements at the World Bank that typically leverage a variety of public and private resources in support of an international initiative. So it's a financial intermediary fund that is being proposed to deal with the financing. Finally, let me mention one other thing that I think is well worth watching if you really focus on global health. And that is a proposal to strengthen the global architecture for HEPR, Health Emergency Preparedness, Response, and Resilience. WHO calls this HEPR. And notice that it's health emergency preparedness, response, and resilience, not pandemic preparedness, response, and resilience. It's really meant to be broader for other potential health emergencies. The World Health Organization in March, about a month ago, published a note on this, a concept note. And they're working on a proposal. They had initially promised that it would be out by 21st of April, but it'll come out later. It's been delayed. And what they're doing is they're highlighting, they're saying that COVID highlighted the need for a stronger and more inclusive health emergency preparedness, response, and resilience architecture. And the Director General will be presenting these proposals, as I said. The idea is to have a broad and inclusive consultation process involving member states and many others in advance. And in fact, Dr. Tedros and his senior leadership, after they had published this concept paper on the web, came to Washington the week of April 4th. His senior leadership for emergency response. And these were many of the people you may have seen on the press conferences that WHO has been holding over the course of the pandemic. Mike Ryan, who heads their emergency program, and Dr. Maria Van Kerkhove and others were all in town here in Washington, D.C. that week. Several of us met with the Director General and his staff at a roundtable on strengthening the global ecosystem for health emergency preparedness and response and resilience. And we offered comments on that concept note that he's planning to finalize. And they've been getting a lot of other input. WHO says that the document that they're going to be issuing with their proposal will outline the overarching principles of equity in access and outcomes, inclusivity of ownership by all countries and sectors, and coherence in the alignment of systems and their financing and governance with the existing instruments and mechanisms in global health. And they want to do this on the national, regional, and global levels. And they're talking about an emergency continuum that involves systems and capacities, governance, and financing. And that gets into a lot more specifics, but it's basically the systems and capacities, the governance of the whole thing, and how to finance it. And I think this is something that will be possibly very influential, but we'll have to see, because it's being developed by WHO, but everybody knows that the global health system includes other UN agencies, such as UNICEF and the UN Office for the Coordination of Humanitarian Affairs, and the UN Secretary General's Office, and many other entities within the UN system. You have multilateral agencies that are not part of the UN system, such as Gavi, the Vaccine Alliance, and the Global Fund to fight AIDS, tuberculosis, and malaria, which has been doing more on strengthening health systems. You have the Bill and Melinda Gates Foundation, which is such a huge funder, as well as Wellcome Trust and other foundations. You have the role of the private sector. We can all be thankful that the pharmaceutical companies were so quick to be able to approve these vaccines for COVID-19 vaccines produced in record time. You have another whole network of civil society organizations, the regional organizations such as the European Union, the African Union, and now the Africa CDC, and so many others. There's so many elements out there in this global health architecture. We'll have to see what these proposals from WHO are and how they fit in with all of these other actors. So that's something else to be watched if you really focus on this, because that proposal at WHO is expected to produce, should be out in the next week or two. In conclusion, I'm going to read a fairly lengthy quote from a journal article that was published in January 2021, Pandemics Throughout History. It's by Jocelyn Pire and Guy Boivin. And it really makes clear the connections involving climate change, the environment, and public health, and the fundamental concern that we need to be prepared for a future pandemic. Let me quote. Plague and cholera pandemics first disseminated along trade and military routes. Thereafter, the geographical spread of pathogens followed the movement of human population through rail, ship, and air travels. Nowadays, the globalization of travel and trade of animals and animal-based foods further increases the spread of infectious diseases and the speed with which they are disseminated around the world. land use and urbanization to accommodate agriculture and living areas, modify the habitats of pathogens, hosts, and disease vectors, and affect the transmission dynamics of infections to humans. The geographic distribution of disease vectors and hosts, as well as the living habitats of microorganisms, is also affected by climate changes and could potentially increase the spread of pathogens. Increased contacts between animals and humans through breeding, hunting, wet markets, and trade of exotic pets also favor the risk of spillover of zoonotic pathogens. The spread of infectious diseases is thus expected to increase due to human activities and their effects on the environment. Epidemics and pandemics will also occur more frequently and will represent new challenges for public health. Not a very optimistic message. But the message is clear that we need to be better prepared for the future. The world needs to have well-functioning and well-funded systems in place to prevent, detect, and respond to emerging infectious disease threats in a coordinated international approach. We have elements of that today, but we really don't have a full and adequate system. Given the hesitancy on the part of some governments, given the divide between those in the global north who are focused on global health security and those in the global south who are focused on global health equity, it is not at all clear that the world will get its act together, that a pandemic treaty or a financial intermediary fund or fundamental revisions to the global health architecture will come to fruition anytime in the near future, so that we can all be better prepared for the next pandemic. We shall see. It's a very important moment. Governments need to be engaged. Citizens all around the world need to be engaged because we don't want to let this opportunity pass. We need to make changes in the system. And I hope these do come to fruition. Thanks very much for your attention.